Dr. Carolyn Schnakers.
Hi,
Here.
Hi everyone. I will try to share my screen. I hope it will work. So as Daniel said very nicely, I'm the assistant director. I'm just standing here. You cannot see me because I don't have any camera. I'm working on it here because Zoom is kind of a central part of our work now. So I need a camera. But anyway, so I look like this here. And I have been working at Casa Colina for more than 3 years now, and it's a lovely environment. We have our own building, and it's a very lovely team, and it's a setting that is kind of combining everything in one, meaning that it's a continuum of care. So we have really acute patient with traumatic brain injury, and then subacute to long-term with TLC. So we really have the whole spectrum here, and we really wanted to have a better characterization of recovery, particularly in long-term TBI, because believe it or not, it's not very well understood how the brain is still changing in a very chronic stage. Actually, the TBI model system that you probably know has been working for more than 10 years now and showing some very interesting data on patients with moderate to severe TBI and showing that this is not an acute issue. This is not only in an acute setting that you see that TBI patients are showing difficulties. And we know that as clinician, you know, it's just a chronic disease, and it's just now that start to be recognized, weirdly enough, because we have data that has been showing and following this patient or patient with chronic TBI for so long, showing that actually, you know, if you don't pay attention, if you don't have a follow-up care for this patient for years, they actually fall into cracks, and they can have a lot of complications. They can have a low quality of life, and all these things that you know already, all of you. So this starts to change, so it's a good thing. But in order to change even more, is to find some effective therapeutics, and it is not very very well done right now. And the reason is that we don't understand really what is happening in a chronic brain with in a chronic traumatic brain injured brain. So we have been trying to start addressing that. We did a small study just to see, and now we are continuing that study with more collaboration with Pomona Valley and trying to follow patients from very acute stage to a very chronic stage. But what we decided to do is to follow just a little subset of patients and try to see how blood can help us to better understand what's happening in the brain. Blood is kind of a, sorry. Oh, sorry, there was a question, I thought. So blood is actually an interesting way to assess how the brain is doing. It's inexpensive, can be done at the bedside, and quite very specific to some brain damage. And so it has been shown in the past that not only blood-based biomarker can be of prognostic value, particularly in acute setting, but also can be indicative of a diagnosis. For example, this one here, ubiquitin, that you maybe have been hearing of lately, has been associated with the diagnosis of mild TBI and concussion. Which sorry. Yeah, so sorry. My TBI, which has been very hard to really diagnose, because even on a very good MRI, it's sometimes very hard to see any lesions in the brain. So some people say, oh, it's just psychological, and so we need to come with additional marker to say, well, no, we have here a proof that there is something happening in the brain, and there is not some neurotoxicity, and we need to affect that neurotoxicity and impact on it with a treatment. So you have here very interesting, to me at least, graphs that just represent how much this indicator varies. And you can see that so this is the acute phase and this is the very chronic phase. And you see that in the very acute phase, there's so much going on, okay, in the brain, we know that. But as the time passes, there is still some things going on. There is, for example, PTO that has been associated to neurodegenerative diseases, and we know with chronic traumatic encephalopathy that we need to be careful and monitor chronic TBI because it might actually be evolving to that, not all the time, okay? So it's not because you have a chronic TBI that will end up with a neurodegenerative disease, but we need to identify this patient, and we need to, when we identify them, to have a treatment and better know what area in the brain is progressively degenerating, and what are the treatment that we can do, and at which time point we have to do that to allow this patient to better recover. So we're interested in very different biomarkers in parallel to these blood-based biomarker, just because when you are interested in one blood-based biomarker, it's very good, but it gives you just a part of the story. And if you want to better understand what this biomarker mean, you need a lot of different information to better comprehend what this biomarker mean and what's happening in the brain at the same time that this biomarker is changing. So what we did is to actually do MRIs, EEG, and neuropsych. What we did is this. Every month for 6 months, and that's the reason why it was really, these patients were dedicated. I mean, I still very amazed of each of them who accepted to be a part of this protocol. But during 6 months, every month, they would have a blood sample done. They would have a neuropsych assessment done. They would have an MRI DTI done. And they would have an EEG every month for 6 months. So it was very demanding. And we had a few patients that accepted for this preliminary study. We had 8 patients, 8 TBI patients, moderate to severe, 7 males. They were between 21 and 44 years old. And 5 were actually severe TBI. Most of them were kept. We wanted, that's the reason why there is also a few of these patients, is that we wanted to look at the age and look at the time point. So we wanted really to take chronic, but not too chronic, because then it's very hard to interpret the data. And so we decided to take between 1 year and 2 years. So that's the reason why it was kind of very hard to recruit this patient, because we were very specific on the inclusion criteria. So it is what we found. So what we found is that among all the different biomarkers that we took in account, is that yes, p-tau was the one that came up, but to our surprise, p-tau was not related to a negative outcome. It was actually related to a relatively good outcome, which has been, I mean, it's surprising to hear that, because p-tau really has been a higher p-tau, an increase of p-tau through time, has been related to Alzheimer's disease, and p-tau, CTE patient who have been, where there has been dissection of the brain. There is also collection of amyloid plaques, and tests have been showing that PTO is definitely related, an increase in PTO is definitely related to neurotoxicity in these brains. But in our study, it was actually interesting to see that through time, there was a difference first between moderate and severe. Severe actually had a very stable p-tau, and I'm talking about patients again that were chronic, so 1 year, between 1 year and 2 years. So they were relatively stable for the severe patient. But the statistical analysis that we did, looking at the curve through time, showed that there was an increase for the patient with moderate through time. Moderate TBI showed an increase through the 6 months, and it was associated with an increase of working memory, increased working memory, better improvement of function after these 6 months. And in the brainstem, you can see here, this is the brain, but this is not this is not the entire brain. Don't worry, your brain do not look like that after TBI, but it's rather the center of the brain. This is the subcortical areas, and more exactly, you can see here particularly that the brainstem was expanding. It can be pathological, so it's difficult to interpret really. We know that when there's an atrophy of the brain that is identified, we know that it's a diminution of voxel, of matter in subcortical area. We know that it's a bad thing. We know it's related to atrophy. But when there is an expansion, it's really difficult to see, to say anything. It could be a neuronal growth, but it could be abnormal pathological growth too. But here, since it seems associated to different positive outcome, we thought that it was actually a bit surprising. But when you look at the literature, it has been shown very recently that p-tau might be related with more positive cognitive improvement than what we could really understand. So what we are trying to understand right now is what really does mean an increase of p-tau in the recovery of the brain. Is it that transiently, the p-tau could be increasing, and that would be related to a neuronal growth rather than really related to a neurotoxicity? Might it be that it depends what kind of increase we're observing? If there is a moderate increase, that might help the brain, but if it's too much, it might actually become neurotoxicity. So it starts to be a very nuanced discussion, saying, well, you have an increase of p-tau and that's it. So this really helped us to better focus on what candidate could be interesting in studying in chronic. And right now we are trying to develop NIH proposal to better study p-tau in a chronic brain, and what are the different stages of recovery too, because again, I told you, it means different things that you're looking at the brain at 6 months after impact versus like a year, even 2 years after. So really try to address all this. It's very ambitious, but it's definitely something that should be done. So yeah, so that's a bit what we are doing right now, and we are still recruiting. If there are some of you that would be interested in participating, you just come to us and don't hesitate to let us know. Daniel has my email address. So
maybe if you could take this moment here, Dr. Schnakers, to kind of tell everyone how, if we were interested in getting involved or participating, how we could do that.
Well, simply shoot me an email. It's
Okay.
as simple as that. You send me an email saying that you are interested in participating. Of course, there are inclusion criteria, so we will have to look to these. But you know that's really the first, the main thing you should be doing.
Okay.
It's as simple as that.
Okay, great, great. So